Good afternoon. This is Ruby with the American Lung Association in Minnesota. Welcome to our 2016 Asthma Webinar Series. This is our third webinar in our year-long series on special considerations in asthma. Thank you to United Health Foundation for supporting this webinar series, and a special welcome to our United Health Foundation partners in Asthma Action Coalitions joining us across the Upper Midwest. Before we get started, we have a few housekeeping items to cover. All lines are muted. If you have a question during or at the end of the presentation, please chat it into the chat box on the lower right-hand corner of your screen. Also, a copy of the recording of today's webinar will be shared with all participants, and feel free to share with your colleagues. And finally, we invite you to register for our April webinar, which we will include a link to in our follow-up email. And the April topic is on masqueraders of asthma. We hope you can join us. Now I would like to welcome Wendy Brunner, who will be presenting today's webinar on depression as a risk factor for the development of asthma in adults. Wendy Brunner is the epidemiologist for the Minnesota Department of Health's Asthma Program and has served in that position since 2002. Prior to that, she worked on occupational respiratory disease projects, including the investigation of mesothelioma among iron miners in northeastern Minnesota. She has a master's degree in environmental and occupational health and a PhD in epidemiology from the University of Minnesota School of Public Health. Thank you for joining us today, and I will turn it over to you, Wendy.
Sounds good. Thank you, Ruby. Good afternoon, everyone, and thank you to the American Lung Association for inviting me to present on the research that I've done on depression and asthma in adults. I'm going to start with some data. I'm an epidemiologist after all, so some data on depression and asthma, and then talk a little bit about what prompted me to get into this research, and then spend the majority of my time telling you about the research study. Oops, let me get this slide here. And what we found in our research. So depression is a common condition in the U.S. Nearly 16% of adults report that they have ever been diagnosed with a depressive disorder, and 8.7%, or nearly 1 in 11, report current symptoms of depression. 6.6% report that they have suffered from an episode of major depression in the past year. And depression is costly. It's estimated that depression cost $83 billion in direct medical expenses and lost productivity in 2000. And that's the most recent year of data that I could find that includes the indirect costs, which I think is important. As you all know, asthma is also a relatively common condition. An estimated 24 million Americans, including 17.7 million adults and 6.2 million children, have asthma. According to data from the World Health Organization, asthma impacts 300 million people of all ages worldwide. And it's been estimated that asthma cost $56 billion in direct medical expenses and lost productivity in the U.S. in 2007. So clearly both asthma and depression are relatively common conditions with significant impacts on public health. So my interest in conducting research on depression and asthma, or depression and mental health in general, was prompted by my observations of a connection between the two conditions in my work doing public health surveillance of asthma for the Minnesota Department of Health Asthma Program. And this slide is showing an example of that data. This is data from the Minnesota Student Survey, which includes students in schools across Minnesota in grades 5, 8, 9, and 11. And what you see here is that among students who had a diagnosis of asthma, 20% reported that they had been treated for a mental health, behavioral, or emotional problem, compared to only 11.6% of students who had never been diagnosed with asthma. And then another example with adults, and this is specifically related to depression. The slide is showing data from the Minnesota Behavioral Risk Factor Surveillance System. It's a survey that's conducted of adults every year by the Minnesota Department of Health in conjunction with the CDC. And this is showing that 31% of adults with asthma reported that they had been diagnosed with a depressive disorder compared to 13.9% of adults without asthma. So in this case, more than twice as likely to report, people with asthma were more than twice as likely to report a diagnosis of a depressive disorder. These associations are, that I've seen in the surveillance work that I've done are consistent with many studies in the literature showing strong associations between asthma and different measures of mental health, including depressive symptoms, depressive disorders, major depressive episodes. Studies also show that asthma is linked to poor mental health in general, anxiety, and poor health-related quality of life. In addition to the high correlation between these two conditions, asthma and depression, having depression can impact awareness of asthma when you have both, and it can impact adherence to asthma treatment, which can lead to poor asthma control and an increase in asthma exacerbations. So the studies that I just referenced, though, are all cross-sectional. So that is, that asthma and depression were measured at the same time. So you can't make any inferences about temporality or which came first. You only know that the two conditions are highly correlated. So the question guiding my research then was simply, which comes first? And this is the approach that I decided to take, looking at asthma and depression prospectively from both directions in the same study population. So to do this, I would need to be able to measure depression in a group of people who didn't already have asthma, and then follow them over time to see what proportion of them developed new onset asthma, and then measure asthma in a group of people who didn't already have depression and follow them over time to see what proportion of them developed new onset depression. And I should say here, when I refer to incident conditions, I'm meaning that they're new onset conditions. That's something that somebody didn't have previously. So fortunately, I was able to find a study population that would allow me to do just this, and that is the coronary artery risk development in young adults cohort. It's an ongoing multi-center prospective study. It was designed to examine risk factors for atherosclerosis in young adults, but they actually also happen to collect information on both asthma and depression, so I could use this for my research. Participants were recruited in the mid-1980s when they were between the ages of 18 to 30. They are from the cities of Minneapolis, Chicago, Birmingham, Alabama, and Oakland. The University of Minnesota is one of the study centers, and that's the group that I was working with. The cohort was designed to be balanced by age, sex, race, in this case African Americans and whites, and education. By balanced, I mean equal numbers. So the way it works is that participants come to the study sites for examinations currently every 5 years, during which the investigators take physical measurements, things like height and weight, and the participants fill out surveys about their health status and other information. So far, these participants have been followed for more than 25 years. There were 5,115 at the original examination, and 72% of the surviving cohort attended the year 25 examination, and I believe they are currently in the midst of the year 30 examination. This slide shows the timeline for the cardia examinations, and oh shoot, well, you were supposed to see this in pieces, but it's not working, but that's fine. So you can see the timeline with the calendar years on the arrow, and then the numbers up above are the cardia examination years, and then the numbers below the arrow are the ages of the participants at each of those exams. And the years at which depressive symptoms were measured are circled in yellow. So every 5 years, starting at year 5, and the asthma, I'll just tell you, was measured at every exam in the same way, with the exception of year 5, was just a little bit different. But the point I want to make here is that there were information was collected on asthma and depression at many time points, and so it allowed me to study this association from both directions. So in CARDIA, asthma status is assessed using the following standardized questions. They're very similar to the questions that I use in my work in asthma surveillance. It's self-reported provider diagnosis of asthma. Has a doctor or nurse ever said that you have asthma? Have you had asthma in the past year? You know, a lot of people understand asthma as an episodic disease. The investigators also assessed medication use, so they were able to tell me about asthma medication use and also age of onset of asthma. So for our analysis, we define what we called prevalent current asthma as self-reported provider diagnosis and current symptoms or asthma medication use. And then when I talk about incident asthma, that will just be the first time that prevalent current asthma was reported by someone, the first exam at which that was reported. Okay, and then depression was measured in CARDIA using an instrument that's called the Center for Epidemiologic Studies Depression Scale, or the CESD scale. So keep in mind, when I'm referring to depression in this study, it's not based on a diagnosis. The investigators don't do a diagnosis, but it's rather a measurement of depressive symptoms using this tool, and then also self-reported antidepressant medication use. So the CESD is a self-administered instrument. The respondent fills it out themselves, and it measures the degree of depressive symptoms in the past 7 days. Higher scores indicate a higher degree of depressive symptoms, and a score of 16 or higher has been validated as an indicator of major depression in the general population as opposed to in a clinical population. So it's a commonly used tool in epidemiologic studies to get at the prevalence of major depression. We also, as I said, obtained information on antidepressant medication use because we wanted to account for participants who were being treated for depression for whom their CSD scores may likely be lower than 16. And for our analysis, we defined elevated depressive symptoms as a score of 16 or greater, or the report of antidepressant medication use. This graphic depicts the methods that we used for our first analysis, so going from depression to incident asthma. First, we categorized our participants, the CARDIA participants, by their depressive symptom status, whether it was elevated or not elevated by the definition I just showed you. At CARDIA exam year 5, which was our baseline, that was the first year at which both depression and asthma were measured. We excluded those who already had asthma because, of course, they wouldn't be eligible to develop new onset asthma. And then we followed everyone else over a 20-year period to the year 25 exam to see what proportion developed asthma. And then we used some nifty statistical methods to actually run the analysis, and I'll skip right to the results of this analysis. So this is what we found. Out of, let's see if I have, I'm not sure if you can see my arrows, but I'll try on this end. We had 865 people with elevated depressive symptoms at baseline who didn't already have asthma, and out of them, 130 developed incident asthma over the 20-year follow-up period. And when you take into account the number of person years, because some people were lost to follow-up, not everybody completed that entire 20-year follow-up. So you account for all of that, you come up with an incident rate of asthma of 9.4 cases per 1,000 person years. And then compare that to the group who didn't have elevated depressive symptoms at baseline. There were almost 2,800 of them, 209 developed incident asthma, and for an unadjusted incidence rate of 6.4. And that difference is statistically significant. So at first glance, it appears that elevated depressive symptoms at baseline strongly predicted the development of incident asthma. But first, before you need to take into account the other factors that are risk factors for adult onset asthma, and that includes things like obesity and smoking, and the fact that women are much more likely than men to develop adult onset asthma. So this next slide is showing the results from our models. The first row is the unadjusted, which I just showed you, and then the second row is showing the multivariable model where we adjusted for age, sex, race, education, study center, smoking status, body mass index, and physical activity based on a score that the cardio investigators calculate. So this was pretty exciting. So what we found was that people with elevated depressive symptoms at baseline were 26% more likely to develop asthma after accounting for these other potential confounders. Okay, and now I'm going to flip to the other direction, asthma leading to incident depression. So similarly, we categorized participants this time by asthma status, whether they had prevalent current asthma or not prevalent current asthma at the baseline. We excluded those who had elevated depressive symptoms or antidepressant use at baseline because, of course, they wouldn't be eligible to develop incident depression. And we followed the rest over 20 years to see what proportion developed incident elevated depressive symptoms. And what we found, so in this slide you can see that there were 188 people with asthma at baseline and 2,800 and change without asthma at baseline. And ultimately, the incident rate of elevated depressive symptoms among those with asthma was 17.2 compared to 17.7 for those without asthma. It's not statistically a significant difference, and it doesn't appear that anything is going on there, but we do need to account for those potential confounders yet. And when we do, we find that the multivariable model is showing essentially the same rate. And I should say relative hazards here for the model that we use are equivalent to a relative, think of it as a relative risk, and that's very close to 1, meaning that there is no association between having asthma at baseline and developing elevated depressive symptoms. I should say that this result was a little surprising to me because I was actually expecting an association in this direction, just thinking about asthma as a chronic condition that may be difficult to control and or result in activity limitations, which I assumed could result in the development of depression. But from the data that you're seeing, that's clearly not the case in this particular study population anyway. So to summarize, we found that prevalent elevated depressive symptoms are a marker of risk for the onset of asthma in adults. It's consistent with a number of other prospective studies showing an association between prevalent depression and incident asthma in adults, and I'm going to show you more on that in just a little bit. However, we did not observe an association between prevalent current asthma and the development of elevated depressive symptoms. The pulmonologist on our team tells me that most cardia participants had intermittent or mild persistent asthma, so it's possible that severe persistent asthma may be associated with subsequent development of depression, but we didn't observe that in our cohort. It's also possible that our cohort was not old enough to see an independent effect of asthma as a previous study has. So this is just a screenshot of the article that we published in the American Journal of Respiratory and Critical Care Medicine in May of 2014. And our conclusion was that this observational study demonstrates that chronic depressive symptoms are associated with the development of adult-onset asthma in middle-aged adults. In preparation for this talk, I really fortunately discovered a meta-analysis of prospective studies of asthma and depression that was published last summer. It was really great to see this and very timely for this presentation. The meta-analysis included 5 studies on depression to incident asthma and only one other study on asthma to incident depression. So I'll talk first about the studies on depression to incident asthma. And you'll see our study in the bottom row there. The studies vary in the age ranges of the study populations that they looked at. They vary in the sample size and the length of follow-up. And the results, with the exception of 2 of the studies, the results are relatively similar, showing a positive association between depression and later development of asthma. The authors of the meta-analysis calculated an overall risk ratio of 1.43. So people with depression were 43% more likely to develop incident asthma. The authors state in their study that this is strong evidence that depression is associated with incident risk of asthma, and they recommend that future studies look into whether prevention and/or treatment of depression could lead to prevention of asthma. And so in that regard, I think our findings, our relative risk, may be lower than some of the others because we did include people who were taking antidepressants and had a CESD score that was less than 16. That it's really about that if you are being treated for depression, it's possible that may be preventing the development of asthma. Something to follow. But in the other direction, interestingly, again, there was only one other study in the asthma predicting depression direction, and that study had a very different result than ours. They report that having asthma is positively associated with later development of depression. The Walters study was conducted in the UK, and it's population-based it's based on administrative medical records and not a research population like ours was. And both asthma and depression in their study was assessed by a medical diagnosis, so a little different than ours. But what's interesting is that the authors suggest that what they found was attributable to health-seeking behavior. That is, that people with asthma were more likely to be going to their primary care doctor more frequently, and thus were more likely to get their depression diagnosed. So I would say with those different results and only 2 studies that fit the criteria for this meta-analysis, that the jury is still out on this one. And by the way, if you're interested in looking at the meta-analysis, I've included the citation at the bottom of the slide. So you may be wondering about, well, what is the biological connection between depression and the onset of asthma? And I can tell you that the biological underlying mechanism is unclear, but multiple pathways have been proposed, and they include the ones that I've included in this diagram. So the association might be due to shared comorbidities, such as obesity, or shared exposures, such as tobacco smoke. However, we did account for both of those factors in our analyses, and many of the other studies did as well. The mechanism may follow central nervous system pathways in the insular and anterior cingulated cortices. Those are the parts of the brain that regulate emotions. The mechanism may follow autonomic nervous system pathways. It's been suggested that the depression is associated with autonomic nervous system dysregulation in the form of cholinergic activation that leads to airway restriction. The mechanism may follow inflammatory pathways. Depression is associated with high systemic levels of TNF-alpha, tumor necrosis factor alpha, which in turn has a pathogenic role in asthma. And the mechanism that's been proposed as most likely involves neuroendocrine pathways, and I'll show that in more detail on the following slide here. Here we go. So this diagram depicts the steps in the proposed neuroendocrine pathway. Starting at the left, depression is associated with dysregulation of the hypothalamic pituitary adrenal axis, better known as the HPA axis, that regulates the body's response to stress. This in turn results in the body's development of resistance to endogenous glucocorticoids. This in turn is associated with an increase in the Th2 immune response, which could increase vulnerability to the development of incident asthma. So based on our findings and the other findings that were cited in the meta-analysis that depression is predictive of the development of asthma, we started thinking about next steps to take, and some of our thoughts are to explore more psychosocial factors, like some of those that I mentioned in the cross-sectional studies that we see where there's an association, such as anxiety. And we're also interested in delving a little bit into the biological mechanisms, where we have data on things like factors like chronic inflammation that we could study to see what role they play. I'd like to acknowledge my co-authors on the study, Dr. Pamela Schreiner and Dr. David Jacobs, who are from the University of Minnesota School of Public Health, and Dr. Akshay Sood from the University of New Mexico. And the CARDIA investigators appreciate it when I include this slide, which shows links to information about the availability of CARDIA data sets for analysis. They are available to researchers, and you just would need to follow those links to get to that information. So with that, here is my contact information, and I would be happy to take your questions.
If you have any questions, can you please type them into the chat box on your lower left-hand side of the screen? We'll give you a minute or two to type those up. All right. We've got a question from Jill Hines. Did you test for any cut point bias on the depression CESD?
Sure. Yes, we, and I think, Jill, you're getting at whether we looked at different cutoffs for defining elevated depressive symptoms. And we decided to use, we initially used a continuous measure, to look at the CSD score that way. But we decided to go with the 16 cut point because that's been validated in other studies, to use that in epidemiologic studies as an indicator of major depression. But certainly that's something that could be, that you could tweak and look at a different way, but we didn't in our analysis. I should say, though, to fit this into a half-an-hour presentation, I did skip a little bit of what we did. One other thing that we looked at was to measure not only what the person's depressive score was at baseline, but we did another analysis in which we looked at the number of times a person reported elevated depressive symptoms prior to their development of asthma. And we added those up, and we found similar results to the one in which we just looked at what was going on at baseline. And that seemed to confirm our findings to us, that we really were seeing an impact there.
We have a request to go back and show the slide with the CARDIA. Okay, perfect.
There we go. And if you go into a search box and type in CARDIA and UAB. It's the website is housed by the University of Alabama, Birmingham. You'll find that there too.
All right, we've got another question. Sarah Kwan, was there a differentiation in depression results in different increasing adult age groups?
That's a good question, and I'm having to look at our paper here quickly. No, I believe we didn't see a difference by age group, but we did, in epi-speak, that would be effect modification. That we did look at interactions by, I believe, by sex and by BMI, and I'd have to look at our results again to remember which ones of those were statistically significant. But if you're interested, I can get back to you on that. Oh, so the short answer is no, I believe we didn't find a difference in results by age group.
How did you isolate other comorbidities as factors that would or could lead to asthma or depression?
How did you isolate? I think if I'm understanding the question right, asking how we decided what variables to control for in our analysis, and I'll go back to that slide if I can find it quickly here. We looked at what factors. Here we go. If I'm getting to the person's question, we looked at factors that were predictive of adult onset asthma from the literature, that we knew may be potential other explanations for what we were finding to make sure that we controlled for those. We were limited a little bit by what Cardia had already collected, but compared to some other studies that were included in the meta-analysis, we actually had more information than some of those other studies did in terms of other variables to account for in the analysis. And get back to me in the chat box if I didn't answer the question you're intending. And I can just jump into on Jill's question about, as your depression score goes down, does your risk of asthma go up? And that's a good question. So again, our analysis just looked at a categorical predictor, whether you had elevated depressive symptoms or were taking antidepressant medications. We didn't look at the CESD as a continuous measure, which would allow us to look a little bit more specifically at the exact scores that might increase your risk and decrease your risk. That would be something that we would need to do separately, but wasn't included in our analysis. I mean, really, this first pass was to really get a sense of which direction were things going, because like I say, I was really assuming we would see something in the asthma to depression direction, and it was surprising to me that we didn't. So we were kind of packed full as it was, and these are really good questions, but we didn't look at that in our analysis. I can go ahead and answer the next question, which is, what is the next step after these findings? What can you do with this information? As I mentioned, we have a couple of some ideas on what we might do next in terms of looking at other psychosocial factors and see if we see the same impact on adult onset asthma. We're also interested in, to the extent that we're using Cardia, the Cardia population, and have data on these variables, to start looking at biological mechanisms and specifically chronic information. If we can look at something like, say, C-reactive protein or CRP, and see whether there's something we can tease out there as to whether that might explain the association that we're seeing. What can we do with this information? I think when we just had one study, we felt that, well, this is just one study. but we could talk about that it's important for healthcare providers to be aware of the potential for new onset asthma in patients with depression. I think with the meta-analysis now, I feel a little bit more confident about saying that, especially seeing the authors of the meta-analysis state something similar, that they think it would be important that future studies look into whether treating and or prevention of depression could lead to the prevention of adult onset asthma.
More questions? All right. I think everyone who had questions has had time to submit. Wendy, this was an excellent presentation, and they're really great questions. I want to thank everyone for joining us, and I want to thank Wendy Brunner for all this amazing information. I would also like to thank the United Health Foundation for their support, and I would like to just remind everyone to register for the April webinar if you haven't already.
Thanks, Ruby.